Good afternoon and welcome everyone to the ongoing COVID-19 working group on survey research methods. We are so glad to have you with us here. My name is Dr. Eric Kendi and I'm an assistant professor of disaster and emergency management at York University in Toronto, Canada. And I'm here to convene and facilitate some of the discussions that we're having here in this group. This week, I'm so glad to have the iCARE team joining us. Simon Bacon and his team of colleagues will be sharing about their international approach to survey-based research examining COVID-19. I think it will be a really nice complement to what we heard last week from the Winton Center. As always, these calls take place once a week on Wednesdays at 4 p.m. Eastern Time, 1 p.m. Pacific Time, and with conversions available around the world. If you want to join, you can join in the group here. Via the Zoom link. You get that by registering at our website, or you can stream live on YouTube and watch the previous episodes anytime. Now, the standard option or the standard approach here is that we invite group members to share any updates that they would like to first. I'm only aware of one update for this week, which would be from Daniela. And so if I can call on you, Daniela, to share your update. And then we will switch on over to Simon and the iCARE team.
Thanks, Eric. I can do that. I indicated to do it possibly next week, but this week.
Oh, sorry. If this works, great.
That's all right. I know I messaged, and we'd just like to really say thank you to you and the group for hosting those, because they're great opportunities for us to learn a bit more about research going on around the world related to COVID-19 surveys. And we wanted to use that opportunity to just briefly introduce what we are doing at the moment. So we are a group of researchers that look at Antarctica as a place. And our main focus with an Antarctic COVID-19 project that we are currently undertaking is on the Antarctic community of practice, primarily around Antarctic researchers and how COVID-19 impacts on Antarctic research and Antarctic researchers, and through that also Antarctic governance. So we are looking at ideally the whole chain of impacts on people who do the research, impacts on the people who run the bases in Antarctica, and on tourism operators as well, because that's quite an active activity in the Antarctic over the austral summer, as well as the implications for Antarctic environmental governance into the future. We are in the process of running a survey. Well, we've actually designed a survey and are just waiting for human ethics approval for that one. Unfortunately, our approval doesn't come through as quickly as that from the University of Cambridge, as we heard last week, which is quite amazing. So we can give you an update once the survey is up and running as well. Thank you.
Fantastic. Thanks so much for jumping in there. And it's one of the things that I really appreciate about this group is that we have participation from folks doing research on a wide variety of topics, from student experiences in COVID to long-term care facilities, to heat emergencies and wildfires, through to people working in Antarctica. And so I'm very grateful for your participation here and glad to have that update. We'll look forward to hearing more as the project progresses. Given that we don't have any other members requesting to give brief updates now, I think we'll reserve the majority of our time for talking with the iCARE team this week. I will give one brief logistical update, which is that I've updated the schedule on the working group website. We have the next 3 sessions confirmed. So this one with the iCARE team. On September 30th, we will be joined by Carrie Funk from Pew Research. She will be discussing some of the think tank work that they've been doing on COVID-19 and the variety of different Pew Research projects. And then on October 7th, we have Danielle Goldfarb from RIWI. They use a really interesting recruitment methodology online where they're soliciting participation from folks who wouldn't otherwise be engaged through the use of 404 landing pages and the like to conduct micro surveys. And so she'll be talking about some of the work with those micro surveys and targeting populations that might not otherwise participate and how they've adapted that in COVID. So those are the next 3 sessions. And without any further ado, I would like to introduce Dr. Simon Bacon and Dr. Kim Lavoie, who will be presenting on the iCARE project. I'll leave it to you to introduce the remainder of your team members and to walk us through what the project is doing, but we're just so grateful to have you with us today, so thank you.
No problem.
I just want to say really quickly, I'm going to let Simon do the formal presentation and as well as introduce our other team members. And it's nice for the invitation. Nice to meet you all. And thanks, Eric, for reaching out.
My pleasure. Thanks for joining us.
So just as Kim mentioned and Eric alluded to, we have a huge number of people that are involved in this, and I'll get to the true depths of the size of this. But there are a few key people that are on the line with us now, and they're here because they've not only put a lot into this, but they have all the answers to all the great questions that you guys are going to ask at the end. So myself and Kim are sort of the leads on this, but other people that are on the call that really need to be highlighted is Jovana Stojanovic, who is a postdoc in our group, who I'm going to introduce a little bit later and some of the things that she's leading. Vincent Gosselin-Boucher, who is one of the PhD students, who has been working tirelessly with Jovana on effectively a third PhD just around iCARE. Catherine Seguin, who is our sort of main admin person for the study, and then Jen Schepenik and I think Guillaume Lacoste is also on the line as well. The two of them are the linchpins of our entire group. So not only do they manage this, but they manage all the other pieces of research that we do on a day-to-day basis. And so really that is the core that has made this a possibility. So just shout out to them. Okay. So the iCARE study, what I'm going to do is go through sort of 3 areas. I'm going to give you, and it should be about 20 minutes worth of stuff that I have to cover. So I'm going to do a brief background of the study, a little bit around the structure of the study, and then some of the key sort of methodological issues that we've had to navigate through as we've put this together. So our background, we're behavioral scientists predominantly, and we've worked in mostly chronic disease, non-communicable chronic diseases. And so this has been an interesting departure, but the critical thing is, as you look at COVID right now, at the core of this is the fact that the only way we can manage it is through behavior-based health policies and getting people to engage in those and adhere to them. But of course, these things come at a significant cost. And so then people are always having this cost benefit weighing. And then what we don't really understand and what we need to do as we move forward is really understand what are the determinants of those adherence elements, and then how do we actually change policy and improve communication to make sure that we get more people engaging as possible, the most amount of people engaging as possible. So our fundamental questions are really to understand what those factors are that drive adherence, and then work out which policies launched when and where and for whom, which I think is a really big emphasis, right? Just there's no universality to this, but understanding for whom these work and who these don't work. And then how do those things then actually translate to reductions in infection rate and then mortality? And ultimately, our goal is to create data-driven recommendations that we can pass to local and international governments on how to optimize their processes to get more people doing stuff that they should be. So just to give you, the magnitude of this, we have 158 international collaborators that are working on iCARE from over 40 countries. The survey part of this is actually made up, is available in 36 different languages. And we are, as it highlights there, this is a very open process. And if people want to jump on board or want to get involved, we're always happy to have more people working with us on this project. There's lots of opportunities. What's nice is we range across virtually every continent on the globe, and we have interesting representation in terms of expertise as well. So we're behavioral scientists, but actually we include a whole bunch of people from epi, public health, medicine, infectious disease, biostatistics, et cetera, et cetera. So it's a really great mix. The actual study itself is broken down into 4 components. We have the survey component, which I'll speak the most about. Then also we're tagging in the Johns Hopkins cases data, the Oxford policy data, and Google mobility data. So, and I'll talk about each of those if you haven't come across them, which I think most of you probably have. And that merged together is the centerpiece of iCARE. So the survey itself is predominantly an ongoing multi-wave Canadian-led international cross-sectional survey. So this means that we're releasing these things about every 4 to 6 weeks, and I'll show you the full schedule, and then trying to capture information. They are not, at this point in time, connected surveys, and part of that I'll explain as we get to it is to do with the ethics and navigating ethics. And there are ways that we capture that data, either through a snowballing process or through representative sampling, and those run in parallel to each other. One nuance to that is as of this new survey, we're just about to integrate a longitudinal study with Canadian individuals. So there'll be an opportunity for people to sign up through the convenience sample and then get tagged into a longitudinal study in Canada. So the actual survey itself is built around 2 theoretical models, the COM-B and the health beliefs model. I've got a picture for the COM-B because it's the more complex. But these are actually pretty standard behavioral theories. And I think one of the things that differentiates iCARE data capture from a lot of others is that the entire data capture piece is built around those models. And then within the actual survey piece, we've got a variety of bits of information. We're capturing social demographics, basic health status, health behaviors, but then importantly, awareness of policies, adherence to policies, concerns around COVID, impacts of COVID, and then issues around contact tracing and vaccine, which are sort of 2 very specific pieces that we know moving forward are going to be critically important. So we're starting to analyze some of that data as well more recently. So this is the COM-B model. So COM-B stands for capabilities, opportunities, motivation, and behavior. And what you have, behavior is driven by people's capacity to do the behavior, their motivation to want to do the behavior, and their ability, the environmental circumstance behind which they can do the behavior. So all of our questions are built into this model. And so it gives us a really nice way of being able to think and understand about all the various different drivers of the behavior. And you can look at the behavior individually or collectively. What it does do is at the back end of that create some complexity from an analytical perspective. So I'll touch upon that in a second. But there is a framework there that we're actually working through. The actual survey schedule is here, and this is the, we're up to survey 5. So what we have actually already in the books is a plan up to mid-January, though when we started off in March, we're like, we'll go to January, and then as long as the pandemic is still going, thinking that hopefully by January we might be good. In reality, that's not going to be the case. So we will, as we get closer into this actual year, start putting a plan together for how we move forward. And what we've tried to do is tag some key timelines around when we've captured data, thinking about various different cycles around the globe of things that happen. So for example, September 15th was a very big date for us because in the Northern Hemisphere, so many countries go back to school around about that time. So it was important for us to get a survey out, a fresh survey out then. People can complete the survey whenever they want. They can complete it multiple times over time. The core of the survey is consistent across every round, but we do make slight adjustments because as the disease evolves, we want to make sure that we're capturing relevant information, and some things aren't relevant anymore. And so there is these small tweaks, but the general core of it is the same. This is just, I think as of today or as of yesterday, the kind of data that we have. So we've got over 65,000 people that have provided us some pieces of data. 55,000 through the convenience sample, about 10,000 around representative samples. I think in totality, there's about 150 or so countries that we have some data for. And for some countries, that's a handful of people all the way through to Canada, where we have the most amount of data, which is close to 14,000 people in the convenience sample and 6,000 in the representative sample. This is just to highlight, these are the three other pieces that we tag together. I won't go into too much of those, but this gives us the breadth of what's actually happening around COVID. The hard part, and this is where Giovanna and Vincent have been doing a huge amount of work, is trying to tag these things together. And so we have to tag everything by date and by country. And, you know, that's a little bit more simpler for things like the cases data, because for every country on any particular day, you have a certain number of cases. It gets a little bit more complicated when you start adding iCARE into there, because you may have multiple people replying on that particular day for that particular country. And so then the tagging process and linkage is a little bit more tricky, but we've navigated through that, and that's working quite well. One thing that's important is that we've made all of this a pretty open process, so that it is possible to get access to the data. We had to, so because of the way that we set this up, so it's totally anonymized. The questionnaire is totally anonymized, so we don't capture any personal identifying information of people, and that allowed us to get ethics pushed through quite quickly, and it also cut down problems around international data sharing issues and personal identifying information issues. And so that's been a huge advantage. The negative is obviously, as I say, we can't tag people together, so we don't know individuals as they've evolved over time. We have, as I say, we have a mechanism, and I won't go into the deep depths of that mechanism, but if people are interested, we can give you the information about how you can get access to the data. And then what happens is we have a repository of things that are in progress. And so this is just a snapshot from before, from a little earlier this month, about some of the papers and areas that people are working on. And this is a process where people can see what's going on. And if they're interested in ongoing projects, we really encourage people to jump in and get involved. The other thing as well, as you can see here, is we've got projects that are global in perspective, but also country specific. So there's a lot of different countries that are working on stuff that's pertinent specifically to them. We have a couple of subgroups that help this process. We have a data management group that Giovanna leads. We also have a policy group that really is looking at trying to get more refined information around country level policies. One of the things I learned personally from this process has been that most of the countries in the world actually have devolved healthcare systems. So like Canada, like the US, you know, the federal government is less important, and regional, either state or province governments actually have quite a lot of impact. And the number of countries that are really a centralized federal process is smaller than I'd ever appreciated. So when Oxford reports its stuff at a very macro level, you don't get a lot of that nuance. So we have a group that's working on that nuance, and there's an off-spin of that that's looking at some qualitative aspects about how policy is perceived in a variety of countries. And then finally, we have a marketing group that manages pushing the survey out and getting people excited about completing it. We've done a fair amount of media coverage, which has been a really interesting process out of this, and that becomes a really key element of how we keep people engaged and keep people coming back to actually accessing the survey part of this. I got one result slide, just because it's a pretty cool, snappy result that we have. So one of the things we're really interested in is face masks and mask wearing. And what you see here is Canada's progress in this process up to about mid-July, and that line has kept going straight. So Canada's doing really well. What's interesting is this is the whole of Canada, but the province we're in is Quebec. So we're a bit funny in Quebec, we're a bit different. And what we found is that we had this phenomenon in Quebec. Pre-mid-May, we were really lagging behind the rest of Canada. And then after mid-May, there's a sudden surge, and so we line up. And what was interesting is what drives that was the leader of Quebec, so the political leader in Quebec, who's got the Premier Legault. That was the date that he came and wore his mask to a press conference for the very first time. Now, this is obviously not causal. This is, you know, it's partly coincidental. But what you see is the people in Quebec who suddenly start wearing masks that weren't wearing masks before, the largest amount of increase is in middle-aged, like rural-based francophones, which is the predominant voting base for François Legault's party. So clearly, you know, this idea of modeling is quite important, and sort of one of the aspects that we sort of identified in terms of communication strategies. And, you know, it's not just about talking the talk, it's walking the walk as well, which is really important, and contrasts to a number of other countries. And we turned that into a very nice little infographic, which is another way that we've managed to spin this out. So this is the final slide, really in terms of highlighting some of the issues. Really nice, building upon the presentation last week, this question of, you know, creating an internationally acceptable survey was really a fascinating process. And it was amazing how things like sex and gender. So, you know, in North America, we have a very, very well-refined conceptualization around sex and around gender and the complexities of all of that, that the vast majority of the rest of the world doesn't. So then it's, you know, the amount of back and forth we went of, oh no, you need this, you need that, et cetera, et cetera. And so we had to make a lot of compromises about, you know, trying to make something that was universally applicable. And that was interesting, navigating it. The other thing as well is that, you know, when you've got 150 people that are involved, everyone wants something of their own unique element that they're interested in. And so, you know, when you put all of that together, you're talking about an hour's worth of a survey. And we knew that if we did that, we'd never go anywhere. So trying to take all of that great advice and all those great perspectives and boil that down to a 15-20-minute survey where you kind of capture the essential essences is always a constant struggle. And every time we revisit a new release of the survey, we go through this very lengthy process of saying, okay, time to update. You can add stuff, but if you're proposing an ad, you've got to take something away because there's just no give anymore in the system. Distributing this internationally. So not only, you know, there's translating the actual survey, but then all of the materials that go with it. So we've done, you know, really the investigators have been, and the collaborators have been phenomenal in jumping on board and translating a whole multitude of pieces. And we have most of all of our social media stuff in all the languages of the survey. And that's been important. One aspect we could get a lot into, and Jovana and Vincent have been working on this as well, the psychometric properties of the survey. So we've got a theoretical structure that we've built upon, but some of this stuff we've had to kind of make up as we go. And then it's so, you know, we've got concerns, and I think we have 12, 13 concerns, and then some of those cluster. Some of them are health concerns, some of them are economic concerns, some are altruistic, some are self-centered. How do you manage all of those when you actually start coming to do analysis? We don't have the answers. We're still working through that, but it's important. Trying to tag all this data together is complex. Making sure there's no gaps in that process. The analytical strategies that we need to employ. And at this point, you know, a lot of what we've done has been primarily descriptive because we've just needed to turn things around and just describe what's going on. But now we're getting to the point where we need to be more sophisticated in trying to understand those groups of individuals that we probably need to target the most to get them engaged and really do their behaviors. And then the final piece, which is information dissemination. And this is the thing that's sort of blown me away most in this process is the speed at which we need to be getting things out. And that's, you know, create challenges because the normal, you know, publishing process doesn't take that, you know, isn't that structured, right? It's really, you got to put it in there, and it'll get reviewed, and then weeks later, and and that still exists in the background. But then you've now got preprint stuff getting out there. You've got, we've had to do infographics. We're starting to do policy briefs and stuff like that. And this is all on stuff where, we don't have peer review that's sat behind it. It's just literally us taking our data and being able to turn it around so that it's usable right now, because we need it right now. And that's been interesting. And then adapting all these things for the different audiences. This is not just solely a scientific audience that we have to satisfy. We need to satisfy the media, we need to satisfy policymakers, the general public, et cetera, et cetera. So these, I guess those last few aren't really methodological per se, but they really sort of challenge, I think, some of the paradigms that we live in from a basic science basis. And they feel sometimes like a bit of a shortcut, but the necessity of having to do this really outweighs some of those historical perspectives. And it's curious, because it's going to be interesting to see what that does moving forward, right? How does that change science once we get over COVID? So there's some of the key issues, and we can get into more depth in some of those. And certainly there are people here that are a better placed to talk about the real nuances of some of those, but they're some of the key things that we struggled with. This is my final slide, which is just to say all the thank yous, the local team, the staff, the funding agencies. This hasn't really attracted a ton of funding. And only recently did we get a CIHR grant for this. Most of this has been built off of a chair that I have and Kim has, and the infrastructure that pre-exists within the MBMC, and just repurposing bodies who couldn't do their research because we were on sort of hiatus, and to really get it moving. So anyone's interested, that's the website that will take you to the survey. That's the contact that you can send an email there, and then it'll get to whoever it needs to get to. And thank you. Take about 20 minutes, not bad.
Just perfectly done there. Thank you so much, Simon. I really appreciate that, and what a great introduction to this project. We've already got some really great questions coming in via the chat. And so I would encourage everyone watching here to feel free to punch in your questions there. I think what we'll do to get started is I'll take facilitator's prerogative here to ask a couple of initial things, and then begin weaving together some of the inquiries from the chat. So please do feel free to share your questions in the Zoom chat if you're on the Zoom call, or via the YouTube chat if you're streaming online. Okay, so if we can rewind for just a minute back to version 1 of the survey. It sounds like you experienced a lot of the same things that I experienced in the survey project that we were doing, of dealing with a wide variety of research interests, of a large team coming together, of developing this initial questionnaire. And so I'm curious to hear more from you about how you sort of developed that and populated it in general, but then specifically how this design that was grounded in these two theories, how that influenced your development of items and the overall instrument.
Yeah, I'm gonna let Kim answer this one.
Okay, no problem. Well, I think, I mean, the inception of this was really sort of, we're, as behavioral scientists, primarily working in chronic disease prevention. I mean, a lot of these models are kind of second nature to us, but I think we felt we really wanted to make a difference, but not just put out a survey, but we wanted a survey that could actually, kind of be, I guess, evidence-based, theory-informed. And that's one of the things we often complain about with some of the interventions that are out there, is that they're not really that based in theory. So I think our basic model was, well, we need to understand what people's perceptions are, in particular the risk perceptions. And that's something that we saw quickly in doing sort of a quick literature search in terms of what predicts pandemic responses, and that is health risk perceptions. And then, of course, we're quite attached to the behavior change wheel and a lot of the work that we do at Susan Mickey et al. And so we thought that it would be relevant to ensure that our different modules in the survey addressed basically the COM-B model of the behavior change wheel. So what are people's motivations? What are their barriers or facilitators? and to some degree opportunities. And this is really more embedded in our sort of socio-demographic questions about, do you have access to sick leave, and are you able to work from home, and what kind of, you know, programs are available, and so on. So we really came at it from that perspective. And I'll be honest, you know, we woke up on a Wednesday and by Thursday we had a version of the questionnaire. I mean, it was really quite quick, but again, I think that, you know, we've put together a lot of questionnaires in our 20 plus years of work. And we took the following week to validate it with a number of behavior experts from across Canada and a few from Europe as well, to make sure we were on the right track. So I don't know if that covers sort of the main thing, Simon, but I think we had some specific questions and hypotheses. And so that's how we really populated our modules, I guess.
I think the only thing I would add very briefly is that the COM-B naturally is a framework that lends itself to intervention development. So, you know, we were really focused on making sure that we could have policy and communication impact. And to be able to do that, we needed to understand how we would go about changing people's behaviors. And so the COM-B became the framework, and then we populated the stuff around the COM-B. And effectively, we send that out to the collaborators and said, you know, here's the room with which you can maneuver. Can you make sure that we're not missing anything major, that you've, you know, the wording is correct, that we've hit the right pieces, and so on. So that was sort of how we went about it.
That's great. Thank you. Can you talk a bit more about how you operationalize the COM-B and others into the specific questions? Were those all things you had pre-formulated into the questions? Were those places where you were really sort of adapting to what you were seeing in the landscape of COVID as it emerged? How did you operationalize from theoretical ideas to specific items and measures that you would use?
I guess very quickly, and I mean it when I said we really put this together quickly. I think we came at it from a pragmatic perspective. We didn't want this to be international. So one of the things that Simon mentioned that is a challenge is how do you assess these constructs in an international way and still retain some measure of sort of face validity, right? And I think that was not to underscore the challenge and when we're formulating some of the questions. But I think we had, I mean, the basics of behavior change, if you know, in the context of a pandemic, is that, you know, you need to be aware of what the government's asking you to do in the way of policies around prevention behaviors. You need to some degree, agree that the policies are important and relevant to you. And we, of course, expected that depending on people's concerns and concern types and what messages the governments were using to promote adherence to policies, there would be some interesting alignment or misalignment there. So we kind of went into it with some, you know, early observations about what was going right and what was going wrong with the pandemic. And of course, starting off with the fact that there was a lot of confusion going in and a lot of misinformation. You know, the benefits of masks is an early example where initially, you know, it was masks are not needed or not effective, whatever, but that was from the perspective of protecting you. But then as data came in, a lot of governments had to flip-flop on that messaging. And so anyway, all of that to say is I think we came at it from a somewhat pragmatic approach in what we're observing, as well as what we know is necessary to get people to change behaviors. And these, you know, a lot of the behaviors that they were asking and are asking people to do around the world are really hard. They're not in our nature. I mean, mask wearing is a great example. If, you know, outside of Asia, it's not really a normative thing to do. And, you know, combine that with early messages that it's not really necessary, or it's not really necessary to protect you. I mean, one of the interesting things we found is that if your messaging is all about do these things to protect your own health, and you're not particularly concerned about your own health, but you are concerned about other people's health, I mean, your concern type is certainly going to have a huge impact on your behavioral adherence. So I think we came at it from the perspective of, you know, we expected beliefs and attitudes to have a huge impact on behavior.
Thanks. Yeah. So to follow a couple more threads here, and then there are some great questions coming in, so we'll turn to those. But I am curious before that to talk about this idea of validating scales and some of the challenges that we have. I mean, particularly in the speed of rollout that there was with initial measurements in COVID. Can you walk us through the process of how you measured validity and tested for that in your survey, and maybe some of what worked well and some of the lessons that you've learned or things you wish you had done since?
Yeah, I'm going to turn this one over to Jovana if you want to start the process, because Jovana's been working the most on this kind of issue. And I don't think we actually have a real answer per se at this point in time. But it's ongoing. But you can tell me.
And I can preface what Jovana can tell you. I mean, basically, assessing what people know or are aware of, or assessing what people are doing based on self-reports is pretty straightforward. Where we've spent more time is in validating concerns and trying to cluster concerns into concern types, so that we could get a sense of, based on who you are and what your concerns are, we thought that that would have implications for messaging. I mean, we still think that. And that's sort of one of the big pieces we've been working on, is the concerns module. Because the behaviors that we're expected to do are what they are. The policies are the policies. People's awareness of the policies in their jurisdiction and their region, are they're either aware or they're not. So we were less concerned about the validity of those things. I mean, the main thing you run into is, you know, the validity of self-report, but that's sort of true of any self-report instrument. So I think I'll let Jovana tell you how we've been tackling sort of making sense of the concerns module, which is something that we've been spending most of our time on, I think, to answer your question. Jovana?
Yeah, just to add, thank you, Kim, for starting the discussion. I think that at least like our initial concerns started when we started looking at individual countries from the first wave of the pandemic, and then we thought about, okay, let's do this from a more like global perspective, because we had a fantastic cross-nation response, and we captured a lot of concerns variables. I think in the wave one, we started with 14 different concerns. Wave two, we had about 18 different concerns. And it's really interesting to kind of understand how these things are clustering together, and understand that maybe some of these things are really correlated among each other. So what we encountered more or less is that health concerns for individuals, like for individual health, is clustering together. Then we had concerns for health of other individuals. Then we had more concerns regarding the general economy, and then financial concerns, individual level concerns. So we are still struggling with this issue and understanding just how, from an analytical perspective, it would make sense to analyze these different factor structures, because my background again is in epidemiology. I'm not in behavioral science, so kind of I wanted to approach this process in terms of communicating epidemiological effects in terms of odds ratio and the risk ratios, and how to analytically approach different factors, and what does this like increase in a factor structure actually mean to from a communication perspective, I guess. Yeah. The other thing that I think was really what I started thinking down the line is how to, because we had different from low income to middle income to high income countries in iCARE. I think what would be really interesting to understand how these factor structures are changing across different economies, I guess. Yeah.
Awesome, thank you. So we've got a question from the audience here that opens up some of the sampling and recruitment questions here about what platforms were used to get community members to take the survey. I'm wondering if you can tell us a bit more about both your convenience and your representative approaches to sampling here in an international context. How did those vary from place to place?
I'm going to turn that over to Kim, because she's head of the marketing group. So
sure. No, I think we initially started with convenient snowball sampling, because that's all we could afford at the time. And we were actually within, I would say, about 10 days, we probably had over 40 international collaborators really, really quickly, who were really keen to get on board and to really be active in sharing the survey. And we quickly kind of devised a strategy where we would, because we're not collecting any identifiable information, you know, we could share it through, our networks and associations. And so, we basically devised a strategy where we would, through our collaborators, get them to then go to their hospitals or go to their universities, go to the, contact lists, if they're members of different professional associations or Facebook groups and all of that. And we basically very quickly started, providing weekly updates and suggestions on how to share the survey as widely as possible. And I think what we did is we initially started with reaching out to collaborators that we knew or that were in countries that we really wanted to target. And I would say within weeks, certainly within about, a month or so, I don't know when we hit the 150 plus international collaborator mark, but it was quite early on. And of course, as soon as you have that many people in that many jurisdictions, then the capacity to really get a lot out of snowball sampling is much greater. And people have been really engaged and really fantastic, as shown by the numbers we were able to achieve in the snowball sampling, upwards of 65,000 respondents since basically the end of March. Now, what we were concerned about, of course, is representativeness through this approach. And so what we did is we scrounged up some money and we approached a Leger polling company, which does kind of weighted representative sampling through their inventory of panelists, I guess you could say. And fairly representative. I mean, short of doing random digit dialing, which we didn't have the funds for. This was a good compromise to kind of at least get some sense that, at least in Canada, was our Canadian snowball sampling data mapping on well to a more representative data set. So the reason why we wanted to get the representative samples in parallel to the snowball sampling was number one, to just get a more robust data set for Canada anyway, and two, to validate sort of the demographic distribution of variables that we were getting in the snowball sampling. And while we don't have representative sampling in all the countries represented by iCARE, we do have it in a few, like Australia and the UK and Ireland. And so that will allow us at least to validate sort of the data in those countries to say with more confidence that they're pretty good. And in fact, I can speak for Canada. And that is, there was maybe one or two variables that were a little bit off, but in general, the distribution of sociodemographics in the Leger representative samples of 6,000 Canadians is maps on really, really closely to the 20 or so thousand participants we have from the snowball sampling in Canada.
Really interesting. I was curious to ask more about that too, in terms of like some of the attitudes and behaviors you found. Have you had any point of comparison between the representative and the snowball groups to see how those sampling methods have affected some of the dependent stuff you're measuring here?
I'm going to give that one to Simon for sure, because he's been digging more into those things.
Yeah, no. So I mean, the Canadian data, as Kim said, is pretty robust. The Australian data, I think, will probably be quite robust. So it's sort of the more westernized countries, it's actually sort of mapping and tracking pretty well, I think. The issue I think that we have more concern about is when we start going to low resource countries. So not even LMICs unto themselves, because we've had a whole series of LMICs that have been on board and have done phenomenal jobs, but there is a reality. So Kenya is one of the countries that we've worked with, and they pushed really hard, and they've got great numbers in terms of the convenience sample. We've desperately tried to get funding to do some representative sampling in Kenya, and it's obviously a lot more complicated because you have to do more on the ground sampling to really get the representativeness. And so when you look at just the basic, who is it who's responding in Kenya is, so it's interesting, there's a much larger number of 20-year-olds than the average population, a lot more focused in urban areas. So, you can clearly see this is around the universities and the people that are connected to the people that are connected to us. So I would anticipate that there'd be a lot more variability in terms of what the representative sample will look like relative to the actual sample we have in the convenience sample. So, you know, I think it's a little bit country specific, and I think one of the greatest annoyances that we've had has been the fact that, you know, governments, and not just the Canadian government, but other governments as well, have really not been interested in jumping on board. You know, the behavioral side of things has not gotten as much funding, I think, as it probably should have, given the importance of it. And that's broadly, that's not just us. We know a lot of other people that have applied and really not been very successful. So, yeah, so I think that's some of the issues that we'll throw up from this.
Yeah, so let's talk a little bit more about that, because we've got some questions from the audience around the funding side of things. So, I mean, some of these have been about what the funding sources are. So maybe we could start on that. You talked about the patchwork that you've had to put together to support this. How did you tactically make that work during such an expedient rollout? And then we can talk about the challenges of sort of more sustainable large scale funding.
Yeah. So once again, you know, I can't underpin how critical people have been in just dedicating their time to this. The amount of hours that the people who translated the survey and keep translating the survey, and then translate the social media, and then translate the messaging, and so on. They're academics, they're working just as hard as all of us are, and they're just dedicating time to this. The students in the lab who, I mean, Jovana, this wasn't what Jovana was doing as her postdoc. And effectively, you know, what she did was put a postdoc on pause and jump fully into this and really, you know, apply her phenomenal skill set to being able to make this the project it is. And just
is basically doing his third PhD.
Yeah, right.
And
so, you know, you've got, you know, PhD students who are just doing stuff. And then, you know, and our staff were really phenomenal as well. We're lucky that our center, we have a nice center. We've got quite a few staff members. And of course, everyone was, there was no activity going on. I mean, we couldn't do any testing or anything like that. And we paused all our projects. And so everyone really was happy. Whether they were happy, they seemed to be happy, but they jumped on board really fully into this, and it's really that kind of group effort that made this possible. So I think, you know, the man hours and the dedication, it was really at the core of this. The funding part really becomes important in terms of the representative sampling piece.
Well as, I'll just want to add, as well as the capacity to analyze all this data. So we have one full-time data analyst who's responsible for all of our studies, which is fine until we have this massive amounts of data that, you know, people want. You know, I'm on a federal advisory board. They're like, oh, can we have this? I'm like, you know, and so we don't have that capacity because we don't have any funding. So I think that's another big challenge that the funding would have helped with.
Yeah. So just being able to turn the data around that fast, and some of the complexity, as I mentioned, on the analysis side is difficult. And we have good expertise, and we're gaining expertise all the time, especially around the biostatistics. But then it's going from capturing that data, processing the data, and getting in a format that you can then put it into their hands so they can actually then do stuff with it, which has been one of the key critical challenges, and we're close to, I think, getting over that hump. And certainly funding earlier would have helped. But going back to so briefly, just saying, you know, the representative sampling piece. So, you know, the UK managed to get some funding, Australia got some funding, Ireland got some funding, and you know, what they did was leverage our capacity to aid them in doing representative sampling. So they used our backbone of things. And work with companies locally, cut down their costs, which meant that we were able to really make some headway there. But you know, we still keep applying for funds because we still want to keep working on getting those extra representative samples. So if anybody has any great ideas, we're open to that.
We've only submitted 15 things, but that's okay.
So that, I should say, to that earlier question, was in here from Susanna. So thank you for that, or Susan, thank you for that. Daniela asked a question in follow-up about the sort of way the funding infrastructure works going into a second wave. Do you have any perceptions of what the funding environment and ecosystem looks like as governments are faced with second or third waves and the prolonged crisis? How does that play out, and what are the challenges and opportunities that you face as researchers?
I think one thing I could say quickly is that, following on what Simon said before, sorry, Simon,
No.
I mean, we're biased, but I don't think it's too much of a stretch to realize that if we don't address behavioral issues in the pandemic, we're screwed. And even if when we do have a vaccine, it's still another behavioral issue around the corner. So it's beyond me how there's not much more prioritization of understanding what is predicting behavior in the context of this pandemic. I don't think it's reasonable to just look at the literature to see what we should be doing, because this is so different. And anyway, bottom line is it's beyond me how it's not getting more attention and funding. And if we go, Simon and I, by the sheer solicitation from the media about how interested the general media is, and they're often a reflection of what's going on in real life, like a reflection of what's going on in communities, we can't keep up. So it's like there's this huge disconnect. And just an anecdote, Quebec has some of the worst COVID rates and cases for the size of our province. Certainly in Canada, we're the worst in Canada, and we're the worst compared to many jurisdictions around the world. And yet we have the most laxist school policies, basically none. And today they just launched a new motivational campaign that's essentially a bullying and fear-mongering campaign, where they have a 50-year-old man with a tracheotomy saying, wow, COVID can kill you. And what, Simon, a young girl or a younger girl saying, I went to a party and killed 3 of my family members? What was it again?
That's the only ad they've released so far, as far as I know.
Anyway, there's this other one.
Okay.
Bottom line is, if you ask any reasonable behavioral scientist, they will tell you very clearly, it's almost like behavioral science 101. These kinds of tactics are really ineffective because they raise negative emotions, and these aren't reliable motivators, certainly over the long term, particularly if we want people to adhere rather than comply, and certainly over the long term. So this is really counterproductive. So it's really, I'm going to share a personal concern of mine, and that is certainly the Quebec government is not consulting with the behavioral experts. And I think they're coming out with not only contradictory, but counterproductive messages that I think is going to really fall flat, if not create a whole lot of resistance. So I think there should be lots of opportunities for all of us. I'm not so convinced that there will be, as much as I believe that there should be, and not even because I'm in behavioral science, but because I'm a citizen and I can see what the issues are.
I don't want to get, I go back to the question of funding. So I think government, governments are probably in a bit of a sticky situation right now, because the pandemic is putting a huge economic burden on governments generally. And a lot of governments have put a lot of money into the funding. I think probably the greatest criticism I would have is that really there are very few countries that have actually gone about this in a very coordinated way. There has been some examples to my knowledge. I think Australia did this quite well. And I think there was one of the countries in Europe, and I forget which one, come back to me later. Anyway, effectively what they did, the government said, okay, here's our priorities. Let's get all the experts that we already have within the country, get them together and use them as the hubs around fostering research in, vaccine development, testing processes, survey-based data, behavior change, et cetera. So they went at it a very coordinated structure and tried to leverage all the expertise that was available. But most governments haven't done that. Most governments have done what they normally do. It's a very shotgun approach. And so you've got a lot of money. I take Canada. Canada has spent a lot of money on COVID research. And, there's no real grand plan as to how this all connects together. We recently got some money around mental health funding. And I think there was 6 other people that got funding. At no point has anybody tried to connect those 6 groups to say, okay, let's make sure that even within those 6, we're not doing exactly the same thing, or, communicate around how that looks and how do we optimize and so on. So I don't know if there's going to be enough money in the pot for the second wave or for the third wave that's going to be spent proactively to really address these issues. So I worry about it. I worry about it quite a bit.
So Simon's worry with my cynicism. Great combination.
So unfortunately, we're starting to run out of time here, but I do want to come to a question that Harriet asked, and that has been inflected into a couple of the other ones here, which is about this policy translation piece. And I know, Kim, I met you in the context of a policy translation activity, and we've seen the impact that iCARE has had at a media level. But if you could sort of openly dream about what the system would look like, how the research could be mobilized, what would that be? What role could the surveys play, and how can we get there?
I can start, or whatever.
You wanna start, and then I'll finish strong.
Very fun. So I think if people don't know, Simon and I are married, for those of you who don't know. So that's where you get the banter. So I think if I were to dream, and I don't think this is too far-fetched, I think we need far more targeted messaging, and we need the policymakers, I think, to have a broader understanding of what motivates, and even more importantly, Eric, what doesn't motivate behavior. Because just not doing what's good, I mean, just not doing that is not necessarily problematic, but if you actually do the wrong thing, you can end up much further behind than when you started. And I think the example I gave about the fear-mongering ads is a great example of that. And I think it's counterproductive and it's dangerous. And to some degree irresponsible, because I think there is a segment of the population that is going to be extremely frightened by this. And I think the top of the list are going to be all the parents in Quebec that are trying to get access to online learning because they're afraid of exactly all of those things happening. So we'll see what happens with that. But I think we need more targeted messaging. I think we need policies in place that are far more reinforcing rather than punitive. And if there is sort of fines that come with non-compliance, it's not to be punitive. It's to send the message loud and clear, black and white. The enforcement strategy or the fine is there to send the message that this policy or this behavior is critically important. And I would think that, if you're going to have a policy and you're going to make it optional, that sends what message? It sounds the message that it's optional, that it's not necessary. And so that leaves a lot of wiggle room for people to decide for themselves if this is important or not. And I think that's fine if we're talking about cheeseburgers, but we're not talking about cheeseburgers. We're talking about, a pandemic that circled the world and back, and we are all collectively, what's the word I want? I get the French word sometimes. Subject to everyone else's decisions, positively or negatively. So I think we need to have far more positive, reinforcing, encouraging messages. We need to acknowledge when we've made mistakes as policymakers and say, we didn't have the data, now we do. We need to say thank you for working so hard and making so many sacrifices. This is hard. And we need those of you that are doing it to keep going, because this is why we had a great summer. And so on and so forth. So I think we need to do a lot more things that are motivating in the positive reinforcement rather than punishments. And I think we need to take a step back and acknowledge what good things people are doing. And I don't think we hear enough of that. It's all doom and gloom, and says the cynic, but it's all doom and gloom, and we're gonna rack your knuckles if you don't behave.
Yeah. So just when I meant finish positive, I've got positive messages to add to finish on. I think the first thing is as a group, I think we appreciate we haven't been able to turn around our stuff fast enough up to this point in time into those policy briefs. So that's a big focus for us over the next little while. So the one pager that really policymakers are very used to seeing. So we've working really hard to start generating those and start being able to put those out there and use iCARE data to drive that. The good news is that a number of people now that are connected to iCARE are actually now involved with various different government task force. So we're in Australia, Ireland, here in Canada, on the federal level. We just fed data into the Ministry of Ontario because they had a question, and we had data that could answer their question. So I think we now have a mass of data and enough people in the right places where we're actually starting to feed in information to governments. And, you know, they're actually starting to adjust some of their strategies. So the good news, the really, really good news story is Australia. So the Australian group we've been working with, phenomenal Helena Teed and her group at Monash. And they're directly into the pipeline in the Victoria state government. And their second wave, you know, they advised them all the way through the second wave. And I think the fact that their second wave was done and dusted in 6 weeks, which is pretty phenomenal from the beginning of a signal to taking it all out, was in part, not completely, but in part driven by the information they had captured through iCARE and fed to the government. So, you know, I think we have a long way to go and we have a lot more work to do, but the good news is the governments are starting to understand what we have available and what we can start feeding them, and they're starting to come to us to ask questions. And so we're happy to do that and keep giving it as much as possible. We will go with cap in hand saying, if you give us a little bit more money, we'll be able to do this a lot faster. And we're forever eternally hopeful.
Well, thank you so much to Simon, to Kim, to Giovanna for participating today. I feel like this was a really interesting and insightful glance into everything from the design of a very theoretically rich study through to the actual logistics of pulling this off in the real world under time and funding constraints. And so thank you so much for sharing with us. For members of the working group, next week we will be going, last week we were in the UK, this week in Canada, next week we're heading to the States for the Pew Research Center to learn about their work on COVID-19. And then after that, on October 7th, we will be diving deep into the world of online recruitment and looking at a particular tool for doing that in a random way that reaches populations you might not otherwise. Thank you for being part of this. We'll see you next week, same time, same place. And feel free to catch up with these links at any time on our YouTube channel. If you're not a member of the group, please do join.
Thanks, Eric.
Oh, thanks, Eric.
Thanks, everyone.
Thanks, everyone.
Have a great week, everyone.